Hi, everyone. Thank you for joining us for today's webinar, Dementia360, featuring Dr. Bill Mobley. We are just waiting for him. He's going to be here in about 5 minutes. So if everyone can just hold on, and he will be with us shortly. Feel free to multitask. Hi, Dr. Mobley.
Hi, I'm here. Sorry to be late.
You're okay, and we are live. And just want to thank you again for joining us today. Very excited to hear what you have to share with the audience. I'm going to quickly give you an introduction, and then I will let you share your screen and start your presentation.
Great.
So William Mobley is a distinguished professor of neurosciences at UC San Diego. He received a PhD in neurobehavioral sciences and completed an internship in pathology and residency in pediatrics at Stanford University. At UCSD, he served as chair of neurosciences and now is the associate dean for neurosciences initiatives. He is a member of the National Academy of Medicine and fellow of the American Association for the Advancement of Sciences. Using model systems, his research focuses on the molecular basis of neurotrophic factor signaling, mechanisms of neurodegeneration, and the impact of neurodegeneration on trophic signaling. So we're very honored to have you here today. And with that, I am going to stop sharing my screen, and I will let you share your screen.
Great. Thank you so much, Catherine. I appreciate that. So let me go ahead and pull up the slides and move things around a little bit and go to presentation mode, if I can find that. Here it is.
Got it? Okay.
Got it. And then pull up my pointer. So great pleasure for me to be with you and to talk about this really important problem called Alzheimer's disease. The disclosures that I can make are here. I think the ones that are most relevant are that I'm a co-inventor on patents for a small molecule that may actually be used to treat Alzheimer's disease. Won't speak more about that, but wanted to disclose that. And then I do consult with various companies that are interested in the Alzheimer's disease treatment space. I don't think I'll probably have to tell you that Alzheimer's disease is a problem and an increasing problem. It's common. It's an age-related disorder. Patients suffer the onset very gentle, very hard always to detect sometimes changes in memory, especially short-term memory. But in time, those problems worsen. They have other cognitive difficulties. Their personality changes. And unfortunately, there is no treatment. that works for Alzheimer's disease right now, and they eventually die of the disorder. There are about 6 million people in the US right now with Alzheimer's disease. By 2040, there'll be more than 12 million. It'll cost this country greater than $1 trillion. And it's not just a problem with the United States, the whole world is going to have as many as 60 million people involved, probably now, but certainly in the near future. So what do we do? How do we prevent this oncoming epidemic? We're in the middle of a pandemic now. We know what chaos has been created by the virus. We know that every country in the world's affected. Well, every country in the world will also be affected with Alzheimer's disease. And it's not something that comes and goes. It's not something that bothers you for maybe puts you in the hospital for a while. But like the COVID severe illness, it kills. So how do we prevent the epidemic? So we have to understand the underlying biology. We have to discover treatments that target that biology. We have to translate those discoveries from the laboratory to the clinic. We need to find new ways to make the diagnosis very early, to try to prevent the disease, not just treat it. And finally, we have to test promising treatments in very well-defined, rigorous clinical trials. So first, some lessons in neurobiology. We have to, I think, begin with understanding that this is a disorder of the brain, and it's a disorder in particular of the neurons in the brain. So what we have here is a lesson in neuroanatomy, if you will. So I'm circling a cell here. Excuse me, it's a cell that has a nucleus. This is the cell body of a neuron in cartoon form. The neuron contains 3 parts. There's a cell body with a nucleus, and that's where the DNA is. The cell body has little spikes coming out of it. Those are called dendrites. And those are places where information comes into the neuron from other neurons. The place where it comes in is something called the synapse, and we'll talk a lot about the synapse. It's the place where the end of this neuron comes very close to the beginning, the dendrite of this neuron, and transmits information. Now notice that we don't just have a cell body and these spiky dendrites. We've got this very long process called the axon. And the axon then reaches out to the next neuron in the circuit where it makes a synapse with it, circled here. So we have, in effect, in the brain, neurons connected, neuron 1 connected to 2, neuron 2 connected to 3, and so on and so on. To keep the machine alive, if you will, to keep neurons functioning, because everything we do or say or think or feel is ultimately a product of the way neurons talk to each other. To keep them talking to each other, the cell body needs to send information, proteins, RNA, other information, all the way out to the end of the axon for use in the synapse. Conversely, this neuron needs to talk back to this cell through its axon, through the retrograde carriage of information back to the cell body. So there's both an anterograde process of delivery and a retrograde process of delivery of information. Now let's talk about the synapse. Here's a high-power cartoon, if you will, of the synapse. Notice these little balls, these little spheres that contain little tiny gray balls. Well, that's a cartoon of something called a synaptic vesicle. And when an electrical impulse flows down the axon, it releases this vesicle-containing structure to right here where it pops open and releases the neurotransmitter. And that neurotransmitter then speaks to receptors on this dendrite. So that's how you transmit information from this neuron to this neuron in an anterograde manner, in a going forward manner, if you will. So again, anterograde movement of information, retrograde movement of information key to supporting the ability of the nervous system to function. And it's not just between neurons, it's this terribly important process where they talk to each other at the synapse. Without that to and fro communication, things don't work. So what happens also then, I want to mention specifically the retrograde movement of information. It's via the carriage of really tiny little vesicles called signaling endosomes. And they're the factor that makes them possible is released by this neuron. It's packaged into this endosome and it's carried all the way down the axon to the cell body. And I bring that up because an important piece of the biology of Alzheimer's disease concerns these signaling endosomes. What about the pathology of Alzheimer's disease and clues to its cause? So let's talk first of all about the brain and neuropathological markers. So the first thing to notice that the brain is quite shrunken. So here's a picture, if you will, of the brain cut into a healthy brain on the left side and a brain from somebody with advanced Alzheimer's disease on the right side. And what I want you to notice here is that the overall brain, this is in cross section, is smaller. The spaces between these gyri, these little hills, is bigger. Colored kind of in orange here, that's the layer of neurons in the cortex. But notice that those ribbons are narrower in the advanced Alzheimer's brain. And notice that this structure here called a ventricle, it's a space in the brain that carries fluid, is much larger here because there's been atrophy. And very importantly, notice here, this is a structure called the hippocampus. It's terribly important for short-term memory and learning. But notice its counterpart here is virtually gone. So there's brain atrophy. And not only that, there are changes in the structure of the brain, really throughout the brain, but especially involving cortex. And when we look at a microscope section of the cortex of an Alzheimer's brain, we notice three abnormalities. The one is the collection, the accumulation of a peptide called A beta in something called an amyloid plaque. These are the amyloid plaques of Alzheimer's disease. And these gray structures, these little dark brown structures you see here are these, a large number of these. The second thing that we see is a change in the neuron cell bodies themselves that contain now this very dark fibrils. And these dark fibrils are made of a protein called tau, T-A-U, but specifically a phosphorylated version of tau. So here are the plaques and the neurofibrillary tangles of Alzheimer's disease, but there's another change. And in the Alzheimer's disease brain, here we're looking at individual neurons. The dark dots here, present in very large structures here, but basically absent in the normal, almost invisible in the normal brain, are endosomes. And those are those structures that contain those receptors that have come into the cell at the end of the axon that carry those trophic signals. They're too big. They're too big. So three pathologies demonstrated here. Now, in addition, there are changes in the microscopic structure and function of the brain, specifically involving these synapses. There's also loss of neurons, and there's changes in brain metabolic activity. And this is due to the action of toxic molecules. And let me mention those two molecules as clearly as I can. The A beta that I pointed to, that's in plaques, and it's also present in endosomes, is actually the product of a protein called APP. And through one pathway, APP is cut into small pieces And one of those small pieces is A beta 42, and that is quite toxic, either as a small molecule, as a monomer, but more likely as a collection of those small molecules in a complex, perhaps 4 or 12 in number, and perhaps larger. So soluble complexes of toxic A beta 42. And that other protein, that tau protein that's phosphorylated, it normally is very important for maintaining the structure of those railroad tracks, if you will, that carry those endosomes and other traffic back and forth along the axon. But when they're phosphorylated, they pop off the microtubule and don't work normally, and that can cause problems. And in fact, if you look back at the synapse, you've got at least 3 things going on that make life difficult. One is that A beta is poisoning the ability of the synapse to function, having both changes in the axon and in the partner dendrite. So there's a disruption of information flow there. Secondly, there are changes in the ability of that axon to move information within it because of p-tau. And finally, there's a jam, if you will, a traffic jam involving endosomes that makes it very difficult for them to move back to the cell body to nourish it. So the synapse is literally under attack in Alzheimer's disease. And the net effect of this is that there's a short circuit, if you will. This neuron is no longer able effectively to talk to this neuron. Their communication is busted. There's a short circuit. And the function that this neuron basically participated in with this neuron, that effective back and forth communication, is disrupted, and the function that they served together can be lost. Well, what else do we know? Because of what we know about the basic biology of Alzheimer's disease, we can actually now speak with some confidence about very effective clinical biomarkers, markers that can be measured in people. So let's talk about those a little bit. So first, I've mentioned the brain atrophy. Here, another picture of a normal brain and an Alzheimer's disease brain. We can see differences in brain structure using MRI. We can see that atrophy. In fact, we can see changes in the volume of the brain on a regional basis. Notice here the marked atrophy. Compare here to here, the marked loss of atrophy of hippocampus, for example. We know that axons are also dysregulated in their normal path. And at a functional level, use something called Fmri. We can look at changes in the activation of brain networks, including the default network. And using another tool called PET or SPECT, we can see that glucose use is reduced in the Alzheimer's brain. We can also do biochemical tests that reflect, if you will, the plaques and the tangles that I mentioned. So using PET studies, we can see that there's in fact deposition of amyloid in the brain and of tau in the brain. Again, perfectly complementing these post-mortem images. If we take spinal fluid, we can see that A beta 42 is decreased. Why? Because it's sitting here in these plaques. The brain doesn't release it normally. And we can see increases in tau and in phosphorylated tau because they're being released from dead neurons or dying neurons. And very, very usefully, and especially impressively in the last few years, we've learned that we can use blood to look at these same changes: decreases in A beta 42, increases in phosphorylated tau, and increases in another protein called NFL. This is not the league. This is actually a protein present in axons that's important for their normal function. That protein is released and is now present both in CSF and plasma during the progression of Alzheimer's disease. So let's take a little look. Here's that volumetric MRI, that structural MRI. Here, a normal brain, and here, an Alzheimer's disease brain. Notice again, the enlargement of the spaces inside the brain and an enlargement of the spaces between the gyri, between these little hills of cortical matter on the surface of the brain. And here, the hippocampus, much smaller here than on this side. And here's PET imaging to look at amyloid plaques. So what we see here is increasing red color as we go from the controls all the way to AD. That red color marks the plaques, those amyloid plaques. So really no red here, a little bit of red color in this person with mild cognitive impairment, and even more in somebody who's more along the route to Alzheimer's disease, and here in an Alzheimer's disease patient, abundant plaques in the cortex. What about tau? Well, now we have great tau PET imaging as well. We can actually envisage tau in the brain, in the patient. So notice that all of us have a little bit of tau uptake of this reagent that's injected into the blood. All of us take a little bit of it up in the medial part of a brain called the temporal cortex. But in mild cognitive impairment, and even more in Alzheimer's disease, one sees a spread of that signal, and it's darker, it's redder, it's hotter, if you will. It's more robust, that moves now laterally and superiorly to affect large parts of the brain. So here in mild cognitive impairment, one sees a little bit of streaky tau PET positivity, both laterally and medially. And then in Alzheimer's disease, much more marked, not only in this picture here, but one can see now much more cortical red signal, both laterally and medially on both right side and left side. The pattern one sees with tau imaging by PET conforms beautifully to what one sees at postmortem when one looks at those neurofibrillary tangles that I pointed out some slides ago. And one can measure glucose activity. So here, the nice red signal in the cortex from a normal person. Here, a decrease in that red signal in somebody with mild cognitive impairment. And finally, here in one with Alzheimer's disease, virtually an absence of that red color in much of cortex, especially this part of cortex called parietal cortex. So we have a lot of information about the pathology of Alzheimer's disease, about toxic species, great clinical biomarkers, and we also know that genetics makes a difference. So here's a very nice diagram that looks at, on two axes, the risk of Alzheimer's disease. So from here to here, increasing risk of the disease. And on this axis, the frequency and the population of mutant genes. Now notice up here that presenilin 1, PSN1, and PCN2 are in fact genes along with APP, which when mutated, cause Alzheimer's disease. This is familial Alzheimer's disease. It's autosomal dominant. If you have a copy of that mutant gene, then you will get Alzheimer's disease. So very rare, very, very rare, but causing Alzheimer's disease. If you have Down syndrome, because you have an extra copy of APP, there aren't many people with Down syndrome, you could argue, but almost all of them have Alzheimer's disease if they live long enough. Now, much more common are variations in genes, very common, but with a relatively low risk of any one of them causing Alzheimer's disease. And then finally, there are some genes which, when mutated, are a little bit, they're not so terribly rare. They're at a few percent, but they engender risk that's between low and medium. You'll all have heard of ApoE4, which is not so uncommon and definitely is associated with increased risk, especially if one has two copies of ApoE4. But this, just to remember, these are risk factors, not causative genes. Notice also the color coding, so that the genes that we identify as being very, very important are especially those genes that metabolize APP, that basically allow it to make that A beta peptide. Tau metabolism is also featured here, as are changes in other systems, and we're particularly interested in those that are green colored because those have something to do with endocytosis and trafficking of trophic signals. Well, I mentioned before that to prevent the epidemic, we've got some work to do. And terribly important is to test promising treatments in really high-powered clinical trials. Here's a current listing of all those clinical trials that are underway now in Alzheimer's disease. They abound in number, 126 different agents and 152 trials, but there are no answers yet. But let's go through it. On the outer ring are phase 1 trials. And you'll remember that phase 1 trials are those in which one just makes sure that the compound to be delivered is not toxic. Mostly, it's a safety trial. Phase 2 trials are those in which the compound is checked again for toxicity and safety, but also for some early indications of efficacy, of an ability to actually make a positive difference in the disease trajectory. And those phase 3 trials are typically rather large, and they're ones in which one is trying to prove to the FDA that my drug is both safe and effective. 126 agents, 152 trials. The color coding of those trials are denoting whether they focus on amyloid or tau or some other process. Notice that there's an awful lot of red in different of these two parts of the circle, because one thinks of amyloid as being very important, and tau also. Now, in this axis here are the disease-modifying biologic reagents like antibodies. Here are disease-modifying small molecules, and here are just symptom-reducing small molecules. So, for example, we know donepezil is commonly used. We know that memantine is commonly used. These are versions of those drugs that are apparently still in trials, but we know that two kinds of medicines, cholinesterase inhibitors and memantine, are available to people with Alzheimer's disease and do have some impact, although modest. Lots of small molecules being tested, and we're obviously very hopeful for some of these to pan out. But probably you're more aware of those later stage trials using antibodies to A beta, the most famous of which is aducanumab or Aduhelm, which was recently approved by the FDA for treatment of those with mild to moderate Alzheimer's disease. There is controversy around that. It is owed to two factors. One is that, well, three really. One is that the efficacy is minimal on the basis of the trials that have been published. The second is that there are side effects with Aduhelm that can be quite distressing to patients. And the third, of course, is the cost, which is estimated to be $56,000 a year. Nevertheless, that early sort of victory, if you will, for that particular company is as important as anything for just saying to the field, there will be drugs coming soon for Alzheimer's disease. Be ready for that, because we're going to have to be very careful about how we use them. How we pay for them is up in the air. We need to be very thoughtful as a community of physicians, scientists, industry experts, but also patients and their doctors, and understanding how best to use those oncoming therapies. Now, there's another point I'd want to make. What you'd really love to see is that there would be many more phase 1 trials than phase 2 and more phase 2 than phase 3. While the latter is true, there's too few drugs out here, too few trials in this pipeline. We would love to see more of them out there to take more shots on goal, but also to fill up this middle and phase 3 set of studies, because drugs often fail when going from phase 1 to 2 and from phase 2 to 3. And certainly they sometimes fail in phase 3, not uncommonly. So we've got a lot of work to do when it comes to trials and to effective therapies. Why is it that trials fail? Well, the disease biology of Alzheimer's disease is complicated. We don't really understand disease mechanisms very well. We know a lot, but we don't know all we need to know. Not only that, some mechanisms that are induced by, let's say, A beta 42 may interact in a way to make 1 + 1 = 4, not just 2. So those different disease mechanisms can interact in a way that's very difficult to treat. Think also the fact that we're looking at the aging brain, which itself has changes versus younger age that may make our therapies less effective. Not to be forgotten is that, that there may be more than one dementing disorder affecting a patient. If you're 80 years old, and this is a study that was done, and clinically diagnosed with Alzheimer's disease, when you come to autopsy, it may be that you have the pathology of Alzheimer's disease. Typically, you do. But for you to have only the pathology of Alzheimer's disease is very uncommon. In fact, only about 14% of people who are clinically diagnosed with Alzheimer's disease have only the pathology of Alzheimer's disease at postmortem evaluation, with other disorders that are dementing disorders also present. Vascular disease, hippocampal sclerosis, Parkinson's disease-like manifestations. So one has to be very aware of the fact that the aging brain has a number of processes going on that may make it difficult for specific therapy to work. And not to be forgotten is that these interventions may be coming too late to stop the disease progression. And here it's so important to learn that we're now aware that the pathology of this disease begins perhaps 2 decades before memory loss is noted. So here we're looking at clinical disease stage, and here is the magnitude of the change in the biomarker. Imagine that this period from the initial change in A beta accumulation in brain to the earliest changes in clinical function and in memory, it's about 20 years. So you've got 20 years of disease progression with A beta, or with tau accumulation, or with atrophy of the brain before there are any clinical manifestations. So as Jeff Cummings and his colleagues have said, improved mechanistic understanding of disease onset and progression is central to more efficient AD drug development and will lead to improved therapeutic approaches and targets. And we believe that is the case. Now, I've told you about clinical trials that have failed, but I want to make sure that you understand that there's more to Alzheimer's disease risk than known biological factors. In fact, of all the risk that is not easily identified right now in terms of genetics and clinical biology, there are factors that are modifiable. So 40% of your risk of AD around unknown causes of risk, 40% of that 100% risk of unknown factors is in fact due to 12 different modifiable factors of your life. So that's quite powerful. One has some control of risk of AD simply on the basis of what one does in their life. So these are the 12 factors that were identified: less education, hypertension, hearing impairment, smoking, obesity, depression, inactivity, diabetes, low social contact, excessive alcohol, traumatic brain injury, and air pollution. These are epidemiological studies that were reported in 2020 in the Lancet, by the Lancet Commission, by Livingston and co-workers. Now, here are the key points. It is possible to intervene around these 12 factors across the lifespan. The argument is it's never too early or too late to intervene, and that these risk factors and their interventions differ in impact. So let's talk a little bit about them again. There are sort of two thoughts about why these factors matter. One has to do with the fact that they may impact neuropathology, and the other is that it may increase they may decrease cognitive reserve. So let's go through it. If one could minimize diabetes and treat hypertension and prevent head injury and stop smoking and reduce air pollution and reduce midlife obesity, maybe one could reduce the neuropathological damage. This is a speculation, but it's quite sensible. Perhaps that would also be contributed by maintaining frequent exercise and reducing depression and avoiding excess alcohol. And maybe those same factors, together with treating hearing impairment and remaining socially active and having a higher level of education, could increase your cognitive reserve. In other words, your ability to manage complex data streams more effectively, your ability, if you will, to learn better, to function better. And maybe together that could help prevent dementia. Let's talk a little bit more about these risk factors. So notice 60% of unknown risk, but 40% of risk that can be potentially modifiable. Now, what this other 60% is, we don't know. There may be other factors of daily life that contribute. And goodness knows that there are genetic issues that arise, as we've talked about. But there's this potentially modifiable risk of 40%. So played out over time in early life, decreased learning is an issue that must be considered. In midlife, hearing loss and brain injury and hypertension and alcohol and obesity matter. And then later life, smoking, depression, social isolation, physical activity, inactivity, air pollution, and diabetes probably contribute. If one looks now at a little bit in more detail, one sees that in fact, one can kind of grade the risk that these present. So in early life, less education from population-based studies is held to increase your risk from 1.0 to 1.6. In other words, a 60% increase of Alzheimer's disease with a low level of education. Hearing loss by 90% increased risk. Obesity, 60% increased risk. Let's say diabetes, 50% increased risk. Now, if you take those risk factors and you apply them to a whole population, you get a certain percentage of risk. Of that 40%, 7% is due to less education. So 39% modifiable risk, of that, a fully 7% by lesser education in early life. Let's talk a little bit about midlife and later life. Now, the Lancet Commission talked about COVID-19 and it talked about illness and distancing might increase care in elder stress, loneliness, psychiatric symptoms, use of medications, and might further enhance dementia risk. So I wanted to focus here in late life at the fact that depression and social isolation are quite considerable. They're about 20% of all the modifiable risk. In other words, they're about, if you will, 8% over 40%. So about 20% of the modifiable risk, depression and social isolation. Now, when we recognized that, we thought, can we do something at UC San Diego about that? So I'm now the interim director of the Institute for Empathy and Compassion at UC San Diego. And this was an institute made possible by a gift from Denny Sanford, who's been a terrific colleague and friend to me and to the university. Denny cares a great deal about empathy and compassion, and he gave this gift so that we could explore the brain bases for empathy and compassion and create training programs, especially for medical students, to enhance them. So we focus on basic and applied research, medical student education, faculty and student wellness, and compassionate patient communication. We're eager to engage our community, you, to support collaborative research on empathy and compassion. And so when COVID-19 came through and started being such a terrible problem for all of us, we thought maybe we could reduce social stress and increase well-being and reduce social isolation in the community at large. And what we did is we initiated free Zoom sessions in which meditations were facilitated that aimed at enhancing mindfulness, defined as a non-reactive awareness of the present moment, and compassion. And we got a lot of positive responses. I think by now, we have, in fact, had 20,000 attendees at these meetings over the last couple of years. Not maybe 20,000 different people, but 20,000 people having actually attended these sessions. Because there were such positive responses, we turned to our colleague, Dr. Fadel Zidan from the Center for Mindfulness, and we worked with him to create some online modules in which we could actually measure, are we having an effect? Are we making a measurable difference in people's lives? And so we encourage people to join, to sign up. People volunteered for an anonymous brief survey before and after each session. The sessions were about 30 minutes, given 2 or 3 times a day. They featured mental exercises to enhance mindfulness or compassion or both. The volunteers could choose one or more than one session. They attended when they wished. And on average, their age was 50, but about 22% were older than 65. What we did was to use the visual analog scale. And here you give a 0 if there was no effect, that you had no effect from the training, or if you had, I should say differently, you gave a 0 if you had no recognition of a marker of stress or anxiety or depression, for example, and you gave 10 if you said you had the highest degree of stress or anxiety or depression. So 0 doesn't affect me, 10, I'm very severely affected by these things. And so we use those scales to record then their subjective measures of stress or anxiety or depression and social connectedness before and after sessions. We collected data for the first 200 people. So 200 attended 1 session and 52 attended 2 and 30 attended 3. And then we analyzed the data using the statistical package for social sciences. And the results then that you'll see report the change, the percent change in subjective assessments pre and post sessions or between sessions. So what did we see? So here we're looking at stress. And we're looking at a decrease in stress after session 1 and session 2 and session 3. So every single session proved to reduce stress. And every single session also proved statistically significantly effective in reducing depression by a considerable amount, 40%, session 1, about the same in session 2, and perhaps a little less in session 3. It also increased social connectedness. So there was about a 40% increase after session 1, a huge increase in session 2, and a smaller but significant increase after session 3. So individual sessions, as well as repeated sessions, are having an impact on these parameters. And when we looked at those 65 and older, we saw something very similar, a decrease after each of the sessions in stress, a decrease in depression, not tiny, fairly significant. These are all recorded subjectively by the people who attended, and in social connectivity, a marked increase after session 2. Again, all significant statistically. And when we then looked at whether or not the effect of session 1 was registered again before session 2, in other words, whether it was durable, whether it lasted more than just a few minutes after the session, we saw that there was a decrease of about 6% in anxiety between sessions. Again, we're recording responses from before session 1 to before session 2. So whatever happened in session 1 was still present before session 2. Session 1 worked to reduce anxiety over that interval of time by 6%, depression by 22%, stress by 37%, and increased social connectivity by a little bit. The just to mention, these folks attended on average about 7 days apart, or sorry, about 5 days apart. So those changes were durable for about 5 days at least, perhaps longer. So it's really encouraging that these online sessions can make a difference. So just to summarize overall, AD is an oncoming epidemic that will require innovations in both molecular treatments and lifestyle. Brief meditations presented via Zoom resulted in significant decreases in anxiety, stress, and depression, and increased social connectedness. Those over age 65 also benefited. We're now just beginning a randomized controlled study using standardized measures to evaluate specific meditative practices in brief sessions given over 7 days. It's an ongoing study now, placebo-controlled, really looking forward to having that study be completed. And we're eager for people to join that trial and also future efforts aimed at enhancing well-being of elders and caregivers and just those concerned about Alzheimer's disease. And with that, I'll stop and thank you all for your attention.
Thank you so much, Dr. Mobley. That was a fascinating presentation. So much good information for everyone. I'm sure everyone feels the same way. We have questions coming in. So just a reminder, if you have a question for Dr. Mobley, we're going to take this time to answer those questions. You can put it in the chat box or the Q&A. I'm going to start with the first question from Melanie. Have you seen any link between trauma and AD?
Yeah, I think I can't give you a specific number, but traumatic injury. So just to be very clear, trauma definitely increases risk for AD. I think the question is, to what extent does it do it and how does it do it? And I can't give you that specific number, but it is one of those risk factors identified by epidemiology as yes, increasing AD. Now in the data that I showed, maybe I can run back on that quickly. If I can get back there, I may not be able to get back there. Let me try, Catherine, to stop sharing or start sharing again.
Start sharing, yep.
Yeah, sorry.
Oh.
Okay, here, let's look at trauma if we can. And I'll make that bigger, hopefully.
There you go.
Can you see it? I can't see it, yeah.
I see blue. I see your pointer.
Yeah, let me stop sharing and share the screen again. Go to the slides and do this. Okay, you can see that, yes?
Yes, I can see all the little slides.
Okay, now let me see if I can.
If you
click
do
on
slideshow and present.
Yeah, I'm having trouble with that. I'm going to try one more time.
Okay.
Maybe what I could, hold on just 1 second. Let me try another trick here. All right, I think maybe I've got it this time.
Okay.
Yeah, so let's see. Let's try to make this a little bit bigger.
Okay.
Is that bigger? Yeah. So we're looking. Make it even bigger yet. Yeah. So we're looking at traumatic brain injury. It's 3.4%. Now, that's recognized traumatic brain injury. It's probably a variety of different kinds of brain injury. So what they're saying here in the diagram is you have an 80% higher chance of getting AD if you've had traumatic brain injury. But it's still, when you look at it, only a 3.4% increase per the population. So I think one should say that yes, there's an increased risk, but in fact, that risk over the whole population is still rather modest. Still, traumatic brain injury has to be considered to be very important. And we need to learn more about how it is that it increases the risk of Alzheimer's disease.
Great, thank you. We have another kind of three-part question. So I'll go through these one at a time. First off, such a great talk. You're getting a lot of positive feedback in the chat and the Q&A. So first question, is there a way to incorporate mindfulness training into the life of an adult who already has been diagnosed with AD?
Yeah, I would say yes. Obviously, it's going to be easier when people, though diagnosed, still have the will to and the ability to participate in those mindfulness sessions. My sense is that mindfulness is one of those skills that you can try to develop even when you are relatively severely compromised, because it's really quite simple. One simply focuses on one's breath, for example, and tries to put all the other thoughts out of one's mind. The sort of the awareness of the moment without any distractions. I don't know the data for this, but I would strongly believe that yes, mindfulness practices might still be quite effective and feasible in those people that have been diagnosed with Alzheimer's disease. And we'd love to know that for a fact, but I'd be very surprised if they would not be effective and safe and readily practiced.
Great. Next question. You discussed various biomarkers to aid in diagnosis and treatment. How would someone decide whether to get tested? Symptoms, family history? Are there tests everyone should consider after a certain age, and which tests would they select?
Yeah, so it's a good question because the first question is, do you want to know the answer? And I think maybe 10 years ago, maybe even more recently, maybe one doesn't really want to know the answer because one's pretty well adjusted to what's going on, and there's no medicine after all for this. I mean, you know, there's not any real great medicine for this, so why do I really want to know the answer to this? But that's changing. Number one, it's very good to know the answer because you now are prepared, especially if you think that the answer is clear-cut, right? Now you're prepared to basically think about the changes that you need to make in your life, the arrangements you need to make sure that nothing bad happens to you financially or otherwise as you go forward. So number one is, it's good to know because it helps you protect yourself. Number two, it's good to know because increasingly we're going to have therapies, and you'd want to know whether you have that diagnosis or you're about to have that diagnosis, because now maybe you'll have a chance to join clinical trials to really understand, you know, can we benefit people by using this particular trial? And you'll be in the trial, and your healthcare will improve simply by being in the trial. So yes, to wanting to know because I want to know how to manage my life more generally. Yes, because now I'll be available for clinical trials. And then yes, once those drugs are really approved and are effective and are not ridiculously expensive and have very few side effects, now you'll have access to those drugs in a way that you wouldn't had you not been diagnosed. So I think one can make the argument, yes, but I think one can make it more strongly now because of the fact that we have treatments that are coming along. So I've made the argument that our healthcare system needs to be ready for what I see as an onslaught of people saying, I want to know if I have Alzheimer's disease because I want that drug. I want to, if it's really working, I want to have access to that drug because I want to keep my memory and my life intact. Now, what about the clinical? The biomarkers are very important. And right now, I think what we would recommend in San Diego is that people go to their physician and have a screening test for Alzheimer's disease. And it's quite straightforward. The County of San Diego has a terrific training manual that they've produced. Every primary care physician can readily take that, use that, and make an early suggestion for screening. Am I concerned about this person or not? Once they are concerned about the screening, then they can go on to more further evaluation. Those plasma biomarkers are now proving extraordinarily effective and informative in talking about the risk you have of having Alzheimer's disease. So I think the right approach is to say, I'm going to go to my primary care provider. I'm going to ask that the screening test be done. If it's done and positive, I want to be able to have that person consult with a neurologist around what my next steps would be, but certainly the next steps would include testing biomarkers. And some of those plasma biomarkers are proving as important and as informative as those fancier imaging tests, which cost more money, and as effective as some of those spinal fluid tests that obviously require a lumbar puncture. So I think the future, using these new biomarkers to inform, do I have the disorder or do I not, are going to be extremely powerful and make it much easier for people to get the diagnosis and to be able to believe in it.
And will they be able to, like in that initial screening test you mentioned, 20 years, right? You can be developing this before symptoms present. In those 20 years before there's any symptom, will that screening test should illuminate that you may have it, or how does that work?
The cognitive screening test won't. The cognitive screening test will only turn positive when you're starting to have memory problems. But the biomarker test may in fact be positive years before that, maybe 10, 15, 20 years before that. Now, it seems unlikely that people are all going to run out when they're 60 years old or 65 and ask for those biomarker screening tests. I'm not sure that would be a good use of that resource. But certainly today, one could recommend that if you're concerned at all about your memory, you should see your PCP and ask for a screening test. And quite frankly, we would recommend that those screening tests be done routinely, even in people with perfectly good memory, beginning probably age 60, so that we can anticipate those positives coming up. And someday, I'm guessing, those screening biomarker tests that are sensitive even before memory loss are going to be standard of care.
That's great. It's very exciting that we're going in that direction. The last question of this kind of 3-part series you touched on, what should families consider when deciding whether or not to enter into a clinical trial?
I think we love families that volunteer. I mean, if you think about it, the enormous amount of power that families have to change the field of Alzheimer's is just terrific. We so value participants volunteering. We so value that because without them, we're lost. Without them, Alzheimer's disease therapeutics is lost. So I would argue that the decision to enter a trial would have to be something around on sort of related to, do I think that I might qualify for a trial? And do I think that I might benefit from a trial? And do I think that I might benefit others from being in a trial? I think all are relevant. Now, the one that's going to be obviously the most persuasive is, do I think I might benefit? And the likelihood of one's benefiting from being in a clinical trial is very high because suddenly one's medical care is upgraded. You now have several people who are evaluating you, who are testing you, who are engaging you in tests that help inform them, but help inform you of your health status. One of the best things you can do for your healthcare is join a clinical trial. Even if the trial doesn't work, you've got yourself a doctor and a nurse and a coordinator that now are very aware of who you are, what's going on with your life, and your general medical care almost certainly will improve as well. So I would say, because one thinks that they may be, one might be appropriate for a clinical trial, because one thinks one might benefit, but also because one thinks that one might benefit others, yes, please join clinical trials.
Great. Thank you. The next question, what impacts does falling have on dementia patients?
Yeah, I mean, think about how serious that issue is. Falling is a very dangerous thing for elderly people to do. They break bones, they hit their head, and they have subdural hematomas as a result of hitting their head hard enough, bleeding outside the brain, but pushing on the brain progressively over time, compromising their ability to function. Memory, speech, motor function. So falling is a very serious part of being older. It's a consequence in part of balance problems, but also just motor strength, especially leg strength. Older people should take very seriously the risk of falling, should take very seriously the ability to, consult with others if you think your balance isn't good. To the extent that you can strengthen your legs, good thing to do. But my goodness, avoid falling because of the great risk to your well-being, not just broken bones, but really serious brain injury. So it's just part and parcel of being older, but my goodness, we have to focus on that as something that really needs to be prevented. And now there are new tools that allow one to look at the propensity of falling. And if someone's falling a lot or shows the propensity to fall, one needs to intervene in ways that prevent them from doing so by providing aids, supports, walkers, admonitions to avoid stairs, all those things that would help us prevent falls. We should do everything possible to prevent falls in elderly people because of the terrible injury that can result.
Yeah, falls. Yeah, thank you. Yeah, very avoid at all possible. Well, I think we have time for one more question. What are your personal thoughts on Aduhelm?
Yeah, well, it's very easy to say this. I think it was wrong that it was inappropriately approved.
Mm.
Its clinical efficacy is minimal. Its risk for side effects is considerable. Its cost is exorbitant. I just think that I want to thank Biogen and the people that have done those trials for working very hard to come up with something. I want to thank the FDA for their work in general, but I think that Aduhelm should not have been approved.
Very interesting. Well, thank you. Obviously very controversial. So, great. Well, thank you so much, Dr. Mobley. Really appreciate you joining us today. Great presentation. So much good information. Like I said, we did record the session and we will be sending this out to everyone, as well as adding it to our playlist. We created a Dementia360 playlist on our YouTube channel. So we'll always have this available if anyone wants to reference it for the future. So thank you again, and everyone have a great weekend.
Thank you. Bye-bye.